Hi, I know I'm standing between you and the break, so I'll try to be brief and semi-interesting. I actually find EEG really interesting, so I could talk for a long time on it, but I'm not sure everybody else does. So I'm going to talk today with the assumption that you've actually seen an EEG. I realized after I made these slides, maybe not everybody has had or seen somebody get an EEG, but I assume most of you have, hopefully. If later you have a lot of questions, come find me. I'm going to be here till tomorrow. So the EEG, is a measure of the electrical activity in the brain. And we do a lot of them because, one, it's non-invasive, it's relatively cheap. It's not really, but compared to other procedures that we do. And we have a lot of historical evidence that it's helpful to us clinically to understand the seizures, to determine where the seizures are coming from, to look at the background of the EEG, which gives us insight into the brain's activity. But why does an EEG work? Well, it's based really on the principle that the brain is organized in a way. I'm not sure, yeah, does this show up on both sides if I do that? Maybe. If you look at the thing that looks like a triangle with like an antenna on it, that is a very stylized picture of the brain. And if you look at the top part where it says 1, oops, I didn't do that right. If you see where it says 1, okay, don't touch that. It's the outside of the brain, and then as you go down, you're looking toward the middle of the brain. And it's generally speaking organized in a way that the neurons have that antenna thing is the dendrites and the body is the triangle. And that allows the electricity to be organized. If the neurons were just every which way, you wouldn't really see a pattern to the EEG. But because of this, when a neuron is excited, there's a change in the electrical pattern, and it's very specific. The outside of the brain changes in a specific way. So if you look at the right side picture, it's more of a stylized representation of the brain, which hopefully you know is kind of like a wavy line of neurons. And in some places, the wavy line is sort of toward the middle of the brain, and there you don't get much electricity because the inner and the outer is kind of not too able to be picked up by that EEG on the surface. But when the cortex is really adjacent to the surface, you get a very nice pattern where when a neuron fires, you get a change in electricity, a negative change, and you can see it on the EEG. So we rely on that organization. And I'm going to show you some EEGs to show how organized it really is. But you'll also begin to recognize when you think about it, if the brain is not organized in this way, you get a different pattern, and we exploit that. So hopefully that makes sense. So how do we decide how to do an EEG? Well, historically, we didn't put as many electrodes on as we do now. The typical EEG that most centers do is the one that is the smaller picture. And each electrode is put in the same spot on every patient. So if you go to Suki's at Emory, if you get an EEG there, it would look the same way probably as the ones that we do at Stanford. And that allows us to kind of have a communication across epileptologists, across centers, across research, because everybody's EEG is done in approximately the same way. And to begin with, when you look at it, you see there's about 20 or so electrodes. Each one of those electrodes has a name. The ones with the odd numbers are on the left, the evens are on the right. And we all know, if I say, oh, there's a spike at FP1, that's going to be from the left frontal region. Now, we've gotten craftier over time, and we start to put more electrodes on. And this is called high-density EEG, where more electrodes are present. And those are usually put on with like a net or a cap in some way because it's hard to get that many electrodes on quickly. I am involved in a study in kids with autism, and they are able to get a 256 cap, 256 contacts in and on in about 5 minutes. It doesn't last that long, but it's good for a little while. So we're getting better at that. But I'll talk a little bit more about how challenging it is to do the analysis on that much data. But this is a typical EEG. And I'm going to walk you through this. This is, I think, a normal patient. The age is important. This would not be a neonate. This would not be a newborn. This would be somebody probably 5 or older, because the EEG changes as the patient ages. And the first thing you see is that the way I've divided this up is I'm looking at the left in the first four channels, then I'm looking at the right, and then I'm looking at the left again, and then the right, and then the midline, and then we put eye leads on. And so that's that bottom section, and then the very bottom, that's the EKG. So everybody's EEG in this room may or may not look like this. Mine I've had done many times because the EEG techs have to practice before they get a job. And I actually have a very low voltage beta EEG, so, whatever. I seem to be functioning okay. So not everybody's EEG looks exactly the same, but within the realm of normal EEGs, we kind of know what to expect. The first thing you might notice is that there is this big deflection in the 3rd second. So that little gray line that's going up and down is a second. Anybody know what that is? The epileptologist in the room can't say anything. Just take a guess. What might happen every once in a while that could give you a big deflection? It's not a seizure. It's a normal thing we all do every once in a while. Yeah, it's blinking. And it gives a very characteristic change in the EEG. You see it's more in the front. You see how that deflection is more at the FP1, FP2. And it turns out your eyeballs are also have electricity in them. So basically they're charged, and when you blink, you get a deflection in the EEG. And you also see it, the eye leads down at the bottom also show that. The eye leads are kind of over to the sides of the eyes, and you see there's a big deflection there as well, in case you weren't sure what it was. Then another thing that we have a lot of, and if you've been at an EEG, you'll know that the tech often tells you, relax, relax, relax. Why are they telling you to relax? And the reason is because you get muscle artifacts. So muscle causes artifact in the EEG, and you see some of that on the right side about 5 seconds in. It's that very jiggly stuff. And that's a muscle artifact. That is probably the most common error. If your child's ever been in the ICU and there's an EEG running, or you're having a video EEG, parents are really concerned about that, but it's muscle artifact usually. So that's another normal thing, but we try to get rid of it because it obscures the EEG a little bit. Okay, so awake, they're blinking, a little bit of muscle, they're awake. Organization. So the first thing you might notice about the organization is that when you look at the front, so that would be the top contact, and you compare it to the back of those 4 in a row, you see that it looks different. The front is kind of flat, the back has more up and down, and that's normal. We have this anterior-posterior frequency amplitude gradient, we call it. The frequency is lower and faster in the front and a little bit slower but much higher in amplitude in the back. And we measure that. So I know that a 3-year-old should have a frequency of about 5 in the back, a 5-year-old should get up to 8, an adult 10-ish. And so we just count that activity back there, and that gives us our posterior dominant rhythm. Another subtle thing, which I'm not sure you can appreciate, but when they open their eyes, that tends to go away, and when they close their eyes, it becomes more apparent. So that's another reason why the tech keeps telling you, close eyes, close your eyes. Okay, so those are all things that we use to understand like how the brain is functioning. When you start to look at it more in detail and you have 256 channels, it's much more difficult to look at it by eye. There's just too much data. So then we have to come to a program that actually does the analysis for us. This is one of my patients with Lennox-Gastaut that I wanted to do epilepsy surgery on, if at all possible. So we did a high-density EEG, And we looked for abnormalities in it using the high density, and it generated, in this instance, some right-sided abnormalities. It turns out there were left-sided abnormalities too. I just picked this 1 second. So it's still, I think, a little bit unclear how helpful these high-density EEGs are. They're definitely used in research a lot, and they probably have a role in determining if epilepsy surgery is a good idea. But just by eye, I'm not sure that they're making a huge impact on clinical care. Okay, so this was the wake I showed you before. Now I'm going to talk about sleep. One of the reasons that it's really helpful to get sleep on your EEG is the background looks totally different. It often brings out abnormalities that were not present in wakefulness. So especially in kids with epilepsy, the epileptic discharges can be much more prominent in sleep. Many centers don't always get sleep because, it's the middle of the day, the kid doesn't want to fall asleep. But if I'm concerned about something and I don't see anything on the wake record, I'll ask the patient to come back and get some sleep. So how does this look different than the record I showed you before? There's a whole bunch of patterns that we have in sleep that are not present in the awake record. This thing right there, which I'm going to teach you, looks like a sharp wave, but it's not a pathologic sharp wave. It's called a vertex wave, and it's part of sleep. But you see how it's kind of sharp in the middle there, and it's very much at the midline, vertex, we call it. Later on in the record, as you go down the page, you start to see this very squiggly, up and down, up and down, up and down, and that's pretty diffuse. That is a sleep spindle. So in certain stages of sleep, you have sleep spindles, normal, and you see in this patient, you see it on the left and the right. That's a good sign. You should have them bilaterally at a certain age. In infants, we see them switch back and forth sometimes. So this is a normal sleep background, but totally different than the awake background. So you get more information from having both states. Okay. So what background features are often abnormal in LGS? Well, the first thing is you don't always get that very nice organization. You sometimes have slowing. So I told you that the posterior dominant rhythm, that up and down, should be a certain frequency. It should be maybe 10 hertz. So it should go up 10 times every second. In LGS, sometimes it only goes up 3 or 4 times. So it's slower, which means the neurons aren't talking to each other at the frequency they should be. And that is very nonspecific, but it is often associated with intellectual disability. And then there's sleep architecture. Not only do you see your children or your relatives not sleeping, you also, if you looked at their EEG, would see that it doesn't have normal architecture as well. So not only what you're seeing, they're not sleeping well, they're also not organized during their sleep. And that's so important because memory and cognition rely on sleep to really cement learning. And so if it's not there, you can become quite encephalopathic, have neurologic problems during the day just because your sleep is abnormal at night. So I put these slides out of order, sorry, but organization. So I just took one section, like left or right, and you can see how different it is in the front and the back. So as you go down the slide, you can see that it's very wavy but low voltage. And then as you get to the back of the brain, it becomes higher and a little bit slower. What else is important? Well, mostly the brain does the same thing on the right and the left. So if we do an EEG and there's a big difference between the left side of the brain, remember the numbers that are odd or left, and even are right, you see, looking at that EEG down at the bottom, there's something there that's different. The left side is much more higher and slower. The waves are kind of coming and going, whereas the right side is lower. This is a patient that was run over by a car, and you see that something bad happened actually to both sides, but one side is more impaired than the other. So we look for that, like what's wrong on the left versus the right. Okay. How does epilepsy show up in your EEG? This is from Carl Strafson. I found this nice picture. Basically, what we're looking for are these things called sharps or spikes. There is a difference between the two, but they both basically mean kind of the same thing, which is that they look sharp or spiky, and you can see that in that middle section. That is a spike. And when you start to look at the part of the brain that that's coming from, you can see that it's the area 2. You see it a little bit in area 1, but the main meat of it is in area 2. So how do you get that? And I think Suki mentioned it, but if all the neurons underneath 2 suddenly fired simultaneously, you would get a big burst in your EEG because all the electricity is doing the exact same thing at that moment. And that's how you get a spike. That middle section there, interictal means in between seizures. And you see that you have a spike. It's not a seizure. It's a marker for all those neurons are firing simultaneously together, and that's abnormal, and that is a focus that could cause a seizure. So it's a marker for us. That's why we don't have to capture seizures on an EEG to be able to tell you what kind of epilepsy your child probably has, because these in-between seizure abnormalities are helpful in diagnosis. On the far end, you see ictal, which is the word for seizure, and there the spikes have all come in a row. And that kind of is the conversion of the in-between seizure spikes to an actual seizure. They're just all together and they're flowing from each other. All right, this is probably the most important slide of the talk, so hopefully that was clear. Okay. Okay, what do spikes tell us? We divide them up into very broad categories, into focal, meaning one part of the brain is having that spike, or generalized, meaning both sides of the brain are having the spikes. This is, the middle section is a patient of mine with Lennox-Gastaut who has what I would call irregular generalized spikes. I'll get to that in a minute. But what you see is those big Sharpie things are on both sides, the left and the right, almost simultaneously, but not always. Sometimes they're a little more on the left, sometimes they're a little more on the right. But the next patient has an abnormality in one spot, okay? And if I remind you that odd is left, even is right, and the front of the brain is at the top, you could tell me where the abnormality was on this patient. Anybody want to guess? Right front, exactly. A very prominent spike in the right frontal area. I've changed the amplitude a little bit to make it really obvious, but there's a nice feature to it, which is that it's not only in one electrode. We try to be pretty cautious about calling abnormalities if we only see them in one electrode, because as you know, people move around in the EEG lab, not everybody's cooperative, so you can get faked out by, we call it artifact. But this patient's, that's a real spike because you see it in more than one electrode, and it's quite prominent. So that tells me things about these patients. The patient on the left probably has a more generalized abnormality in the electrical activity of their brain, whereas the other patient seems to just have something wrong in the right frontal region. This is sort of a bonus slide. We use the term symptomatic generalized epilepsy, and I already showed you this. On the far side is my patient with Lennox-Gastaut with generalized appearing discharges. The patient on the other side also has generalized epilepsy, but has an idiopathic generalized epilepsy syndrome. In this case, they have sunflower syndrome. I think I pulled that one. And you see there's a difference. You see it on both sides in both cases, left and right. But you see how kind of, I'm going to use the word beautiful because I think it is kind of beautiful, that discharge is. It's symmetric and it's like so even. The spike goes up, then you get a slow wave, and then the next spike comes. Even though both of those are generalized epilepsy, they're very different generalized epilepsies. And the patient with the irregular one has Lennox-Gastaut, and the other patient is actually cognitively normal but has seizures. And so there's a difference in generalized epilepsies we see. I'm going to show you a couple other features of Lennox-Gastaut's EEG. This is the infamous multifocal spikes, which just means that you have those sharps or spikes in many different areas. I can't even say in this patient that there's really a predominant spot. Sometimes they're on the left, and then you go to the next second, and they're on the right. This is not a seizure. This is the background that this patient has. You also get the flavor from before that when you compare it to the normal background of an awake patient, it's not normal because there's a lot of slowing. Like the waves are not going up and down as frequently as they should. We use the term multifocal when there's 3 areas, basically because it's just a term that we use when we can't count every single spot. And this would also go along with some intellectual disability, like Suki talked about, an epileptic encephalopathy. Okay, the infamous, or I will call it infamous, because one of the key EEG features of Lennox-Gastaut syndrome is something called the slow spike and wave. What I'm showing you here is, remember, each one of those gray lines is a second. So there's about 10 seconds on this page, and each second, most seconds, have a spike in them, but not everyone. And when you start to do the frequency, meaning the spike occurs in this second, then it occurs in the next second, you get something between 1 and 2.5 hertz, meaning 1 second has one, maybe there'll be 2 in 1 second. And this has become really quite important because I don't know if any of you were on Epidiolex, but we've had insurance companies have decided that you have to have this on your EEG to get Epidiolex. So we've had to go back and reread some of our EEGs because in many cases we just use the term slow spike and wave, and now the insurance companies are requiring us to say slow spike and wave at 1 or 1.5 hertz. So it's become important to have that in your EEG reports. A feature of this, the Lennox-Gastaut EEG, that's a little bit harder to find. I actually had to go through quite a few patients to find this generalized paroxysmal fast activity. It is present in some patients, I would say not all. It's shown to you in the 3rd second, and it stands out here. It's just a burst of very fast activity in both sides, meaning that a whole bunch of neurons are firing very quickly and together as a unit. They really shouldn't be doing that. It suggests that the network of neuronal activity is aberrant. You get a spike in the 5th second. Okay, so now my final section is really on the question of, and this is something that plagues all of us, and it's always up for debate. What is a seizure in Lennox-Gastaut, and what is in between a seizure? And that may sound really dumb, but the EEG can be very challenging to read because this is a patient with Lennox-Gastaut of mine, and during this discharge, there was absolutely no change in behavior. The parents were in the room watching the child, no idea that this discharge was occurring. It looks a little bit like a seizure. Remember I showed you that picture where the spikes come in a row? And they definitely come in a row. It lasts about 10 seconds, but there's no clinical signs. So do you call this a subclinical seizure? Up for debate. And it's important because if a patient's having a lot of these, I think intuitively you can understand that this may cause some cognitive dysfunction in that patient. You know, you may not be seeing it, but it might be hard to have a really concrete thought at that moment when that was going on. Another interesting discharge is, this is a patient with Lennox-Gastaut, and there is a seizure on this page, but when is the seizure occurring? So there's this burst of generalized paroxysmal fast activity with some spiking in the background, kind of in the posterior region. And that lasts almost 5 seconds, but the patient's not doing anything. And it's only in the last 2 seconds that there's a clinical seizure. And that is a tonic seizure. I'll show you one of those, where suddenly the background changes. It gets very low voltage. If you look carefully at it, it gets very fast. So it's going up and down a lot. It's so low voltage, it's hard to see that. And that's the classic tonic seizure that is a part of the diagnosis of Lennox-Gastaut. It's often out of sleep. I'll show you another one. Here's another one. You see a few spikes. It starts about the 4th second, and suddenly everything kind of shuts down. It goes low voltage, and then it builds up to a faster activity with spikes in it. It may last 10 to 20 seconds, and that is the classic tonic seizure. I want to leave you with a positive note. Suki mentioned that finding the right medication helps. It's an anecdotal story, but there's a lot of patients with Dravet syndrome being looked at for studies now. And so we recently went through all of our patients with Dravet syndrome, and we only had 2 that were qualified for the study because most of them were not having any seizures, and a few were having only 1 or 2, and the study required 4 per month. So I do think we're making headway on some of the more common disorders that are in the family of Lennox-Gastaut. And that's just, I think, by basically knowing which medicines to avoid and which medicines to try. But another thing that to keep in mind is that some medications do have effects on the background of the EEG. So not only can you get rid of the seizures, sometimes you can clean up the background. I would propose that valproic acid and vigabatrin in specific patient populations can be quite helpful in improving background. The ketogenic diet is another thing that I've seen improve the background quite a bit in certain disorders. This is a patient of mine who's, I think it was 20-ish months, and on the first part of the slide, you see his EEG before we did epilepsy surgery on him. And looking at it, I would say it would be hard to tell which side we should do surgery on. If you look closely, you would say sometimes there's left-sided, sometimes there's right-sided. Maybe, in fact, there's more on the right side. But we did surgery on the left side because that's where, when we did stereo EEG, that's where we found the abnormalities. And you can see that his EEG has markedly improved post that surgery. Now, this is a patient with tuberous sclerosis, so it turns out there are seizures from the right side, which will be resected next. We do a lot of sequential surgeries now because we realize that you can do it safely, and you often do need to take both foci. But as Suki said, the surgery is, if it's an option, really can improve the background of the EEG as well as the seizures. And finally, I want to leave you with who I think are the superstars of EEG. So these are some of the EEG techs that I work with. And I read a lot of EEGs now in outside hospitals, and the tech is a incredibly important person to get a good EEG. They need to know when something's not working and adjust. And when I got there, they basically were like, oh, we never sedate kids. And I was like, oh, that's impressive. But they don't, and they get really good EEGs. So I think one time we've ended up having to do like a sedated EEG on a patient with really severe autism who was quite large and a little dangerous. But other than that, they are the stars of the show, and good ones are hard to find. So if you get a good tech, treasure them. All right. Any other questions? I'll be around if you have them. Thanks.